All right, I think we're ready to get going. So for those of you who do not know me, I'm Holly Longstaff. I'm the Director of Research Integration and Innovation at the PHSA. I'm an ethicist by training. My specialty is in research ethics, specifically procedural research ethics, and I serve the researchers across all of our programs at the PHSA. We're going to begin with our land acknowledgement. This is the land acknowledgement that you would usually see when you're at the PHSA at one of our events or meetings. I am calling from Musqueam, Squamish, and Tsleil-Waututh Nation territory. I'm calling from beautiful West Vancouver between the mountains and the ocean. It's a particularly beautiful day here today. But I'm also aware when I look at this land acknowledgement that so many Indigenous people have been left out of research, either because their data's been left out or they haven't been left out of consent-based studies. And if you don't participate in research, either you or your data, then you cannot benefit from scientific research. So in my work at the PHSA on the PHSA research roadmap, I'm trying to, in the way that I can, address that issue. I'm also very aware of the fact that we are in Black History Month right now, and Black people are another group that has been excluded from research. And in addition, many terrible things have happened to Indigenous and Black people in research, in addition to other groups. And these are huge ethics issues. But I also want you to know that there are 460 plus of you who registered for this event today. And so together as a community, we can do huge things. Before we go on to our speakers, I just want to mention a couple of housekeeping items. You will be muted throughout this event. But if you have trouble hearing, you're to adjust your audio settings. You look at the microphone icon and just go up or down with the arrow. You can ask questions at any time during the event, but use the Q&A icon. The chat one is just for our internal team, should we have any technical difficulties or something like that. We're never going to get to all the Q&As at the end of the event in the last 10 minutes, but we will answer all of them after the fact. In the presentation, there's going to be some Menti polls. Please answer them, so have your phone ready. They are going to be directing the future of this work. And the webinar is going to be recorded. So if you're staying, you're giving your consent to being recorded, and the recording will be made available to a later date. I know that some of our researchers emailed me and said, they're in clinic today or whatever. So we're saying hi to those people in the future, and you can look at the meeting when you have time, the workshop. We're going to be sending you a survey after the fact as well. So you'll get the recording, you'll get a survey, you'll get the answer to all of your questions. The survey is very brief. I know you're getting asked to do so many surveys, so am I. But again, this one really does direct the future of this work. So please answer it. It's very quick. And with that, I'm going to turn it over to my dear colleagues, Ellen, John, and Gina. We're going to start with Ellen. Each one is going to briefly introduce themselves and then say a few words. Ellen will talk about how this work relates to the PHSA research roadmap. Over to you, Ellen.
Great. Thank you very much, Holly. So for those of you who don't know me, I'm Ellen Chesney. I'm the Chief Administrative Officer Research at PHSA. Really glad to welcome you to this workshop today. And as Holly referenced, I did just want to situate this work within the context of the PHSA Research Roadmap, which is a strategic plan that was created to basically strengthen the overall PHSA research enterprise. Led by our Research Leadership Council at PHSA, it includes 32 projects supporting 11 different strategic initiatives. One of those strategic initiatives is to support equity, diversity, inclusion in the research that is conducted at PHSA. So this project is part of that work, and we're just really excited that everybody's here to learn more about it. And I'll pass that on then to Dr. Ogilvie.
Thanks so much, and Holly and Ellen, thank you for the warm welcome. Holly, I think, asked me to speak just to give some context from a personal perspective. So I'm a Black physician and a scientist. I've been practicing for over 20 years. And so I think I bring a unique perspective to this and have really in the past 5 years become a champion for a program here that we're working on called the Right to Participate. And Holly alluded to this, and I think we all know there's been a very tragic, disgraceful, bigoted history of research where certain racialized groups and Indigenous folks were engaged in research without their consent. And they not only did they not consent, they then also didn't benefit from the research. And so that atrocious history, and for those who aren't familiar, need to look into things like Henrietta Lacks's experience in Tuskegee, particularly as it relates to the Black community, really have made us very anxious about engagement in research. And for a good reason, I think really had a lot of trepidation as we engage those communities in research. But the flip of that now is that in many ways, those communities are understudied and they fail to benefit from the massive public investment in research that they have as much right to be part of and have as much right to benefit from. So while well-meaning, some of our efforts have actually now hampered and ultimately limited the engagement of racialized communities in research. And when we fail to measure and fail to engage and fail to have those communities participate, what we are missing are key signals and key issues for those communities to allow them to live to their best life. The other thing, so for me, a huge part of this is everyone has a right to benefit from research findings, and also everyone has a right to participate in research. And as a clinician, what I've seen over the years is that research not only offers a chance for the future to be better and improve health for better, but actually, particularly in difficult circumstances for people, research can give meaning to tragedy. So as someone who has worked in ICUs, as someone who has worked in ambulatory care, I know at very difficult times for people, when they can participate in research, that can often give them the hope that even if they are suffering, maybe future generations don't have to. So I'm also very conscious when we don't measure who's participating in research, and therefore we don't know who isn't participating in research. We sometimes have folks who unintentionally gatekeep or keep those communities out of research. And they then not only don't benefit from publicly funded research and the benefits of research, but they also don't get a chance to perhaps give meaning and have meaning to very difficult times. So I'm really supportive of this endeavor to really start to create a rigorous structure where we look and gather racialized data, we gather data on communities who participate so we can know who's participating and who's not, and how do we encourage and promote and engage those communities in research. So really excited to be here, and thanks for leading this charge.
Thank you, Gina. And now, John, if you could say a few words about your thoughtful and important work at the PHSA.
For sure. Thanks, Holly. So good afternoon, everybody. My name is John Rabenek. I'm Coast Salish from the Snuneymuxw First Nation on my mother's side and English and Irish on my father's side. I work with the Indigenous Health team over here at PHSA as a program manager with our cultural safety and transformation team. Calling in from beautiful Sayout territory in the Greater Victoria area today. And yeah, just really excited to be a part of this webinar and this work that's going forward. Just to share a little context around the CII standard and Indigenous health here in PHSA, last year we had a working group, the Indigenous Self-Identification Working Group, which put forth a recommendation to adopt the CII standard across PHSA. And so one of our esteemed colleagues, Mike Kloss, joked saying, okay, so this will be done tomorrow, I guess, as we adopt this standard and as we get things going, recognizing it's a big undertaking for us as an organization to uphold and to move forward with. We see this as a stepping stone to support PHSA and to guide to ethically and accurately collect data that respects the identities and experiences of Indigenous peoples and other racialized communities. And again, just our commitment to adopting the CII standard is not just a matter of policy or just policy, but it's really a legal and moral obligation to confront and dismantle systemic barriers in healthcare. So I think, the work that we're doing with the working group, I'm really encouraging anybody from across PHSA to reach out to myself and the working group to get involved if you're interested within your program areas or your leadership to really get into this. And I guess the adage comes to mind of you can't manage what you don't measure, and just emphasizes the importance of collecting accurate and comprehensive data for patients and the programs that we're hoping to make a measurable difference with. And so by ensuring the collection of distinctions-based data, PHSA is taking a significant step forward in making informed decisions that reflect the true needs of First Nations, Métis, and Inuit peoples in BC, and creating one accountability mechanism for the health system to measure and monitor progress towards the provision of culturally safe care. Just raising my hands to everybody here and just saying hi to the coordinators of the webinar and just looking forward to the conversation. So thanks.
Thank you, John. And well said. And with that, I will turn it over to our new colleagues, Dana and Liz from CII.
Thank you so much to Holly and John, Gina, and Ellen for getting us started in such a good way and for providing such helpful context to what we're going to talk about today. So My name is Liz McDonald. I am a mom of two, a 6-year-old and a 3-year-old that keep me very, very busy. And I'm also an occupational therapist by training, and I started my career out in Vancouver, working for Vancouver Coastal Health and Providence Healthcare. And I've been with CIHI for about 8 years now as a program consultant with CIHI's Indigenous health team. And I'm calling in today from unceded Algonquin territory. It's now home to many diverse First Nations, Inuit, and Métis peoples, and also known as Ottawa. And my work here at CIHI includes both a personal and a professional commitment to reconciliation through respect for First Nations, Inuit, and Métis data sovereignty, and also through the work we're doing right now to work to advance cultural safety and humility in health systems.
Hello, everyone. I'm very excited to be here with you today. My name is Dana, and I'm also a mom of two. My background is in population health, and I'm a program lead on CIHI's population health team. My work focuses on the use of sociodemographic data to measure inequalities and identify inequities in healthcare access, quality, and outcomes across population groups. I'm joining you today from Calgary, Alberta. I live, work, and play on the traditional territories of the Blackfoot Confederacy, the Tsuut'ina, the Yari Nakota Nations, Métis Nation Region 3, and all the people who make their homes in the Treaty 7 region of Southern Alberta.
And so some of you might be new to CIHI, and CIHI stands for the Canadian Institute for Health Information. We're an independent, not-for-profit organization with a mandate to provide comparable but also actionable information on Canada's health systems and the health of those who live in Canada. And our responsibility is to both provide and publicly report on health data and information that improves outcomes in health system performance and also in population health across the country. And the data we hold comes from a wide variety of sources. These include hospitals, long-term care facilities, professional associations, provinces, territories, and other organizations like regional health authorities. And a large part of our work is about data standards, and the data standards that CIHI produces make a positive impact on healthcare data and are used in each of our data holdings. And we work with stakeholders and rights holders to take a lead role in developing and implementing national standards so that we can enhance the consistency and accuracy and comparability of healthcare information. And another thing that we like to do is help build capacity in the health system to implement standards, and that's why we're here today. And so we've had the opportunity to speak at length with Holly about the journey that PHSA is on. And we also appreciate those of you who are able to complete a few survey questions to give us a sense of what your hopes and concerns are related to the collection and use of race-based and Indigenous identity data. We've heard about the organization's endorsement of the CIHI standard, and we've heard really strong enthusiasm for this work, along with some uncertainty about how to proceed, and a desire to learn more, particularly about community engagement. But we'd really like to hear from more of you using menti.com. We want to get a better sense of what are your hopes for this journey and what are your concerns. And we're going to use Menti throughout today's session, both as an opportunity for you to self-reflect and as an opportunity for dialogue so we can all learn more from each other about how we can support each other to advance this work. So if you have your phone, you can scan the QR code and it will bring you directly to our first polling question. You can also enter the code to join manually on your browser. We'll give everyone a few moments to join, but once you're in there, the first question that we have for you, and you can give some time to think about this, is what are your hopes for this journey? What can we achieve if the collection and use of race-based and Indigenous identity data goes well? So accountability, I love the very first word I see on the screen, and equity. This data can really be used to hold health systems accountable, to hold individuals accountable, and to ensure that we're all working towards a common goal of health equity and better health care. Respect, inclusivity, understanding. There is so much that we can do if we approach this work with the right intentions and the right supports. And following today's session, we will share the results of these Menti questions with you so that you can further reflect on what it is that your peers have shared and to get a sense of where you're at on this journey. And do you have more hopes? Do you have more concerns? I see the word safety coming, and I know for me, a large hope for this journey is cultural safety, both for those who receive care and those who provide care in our health systems. And representation. I loved Gina's comments about the harms that have come through misuse of data and misuse and mishandling of research practices in the past, but also the real reality that people are often invisible in the data, and that is causing harms as well. I see justice, better awareness of the healthcare inequalities that exist now, and hopefully of the progress that we make towards better care and equity in health systems. I'm going to move on to the next question, which is, what are your concerns? What worries you about the collection and use of race-based and Indigenous identity data? And today we'll start the process of hopefully helping you to identify some ways to mitigate the concerns that you have and to address some of the concerns, because there are real risks to collecting this data and they cannot be minimized. But that's something that we can all approach together as we learn and continue on this journey. So yeah, misinterpretation, privacy issues, the risks of perpetuating stigma, risks of exploitation, concerns about asking the wrong question, absolutely. Risks of bias and stereotyping. Risks of abuse, labeling. Yeah, and a misunderstanding, and that word could apply to many different aspects of the work that we're doing here. Risks of discrimination, concerns about discrimination. And while we have many concerns and there are valid risks, what we'll share today are some ideas about how we can mitigate those risks. So today, we'll provide an introduction to the standard that CIHI released in 2022 for collecting race-based and Indigenous identity data. And we'll dive into key processes that are integral to the respectful collection of this information. And that includes community engagement, specific processes for the safe collection of data, and data governance considerations. And to wrap things up, we'll share some lessons we've learned along the way and also highlight some inspiring examples from across the country.
Race-based and Indigenous identity data is essential for measuring health inequalities and for identifying inequities that stem from racism, bias, and discrimination. This data can be used to inform actions and interventions to improve health equity among racialized groups. CIHI's work in this space dates back quite a few years. Some notable highlights on our journey are shown on the timeline on your screen. In July of 2020, CIHI released a discussion document on proposed standards for race-based and Indigenous identity data collection. We used this document to stimulate and facilitate conversations with a wide variety of individuals and groups, including those who represent racialized and Indigenous communities, subject matter experts, research organizations, and federal, provincial, and territorial governments. Based on this extensive engagement CIHI released the guidance document in March of 2022. In April, we also made it available as an optional field to collect race-based and Indigenous identity data in DAD, the Discharge Abstract Database, and NACRS, the National Ambulatory Care Reporting System. We also added some information to our Measuring Health Inequalities toolkit to help researchers and analysts use this type of data. As we engaged on the topic of race-based and Indigenous identity data collection, there were several recurring themes that came up. There is a real fear of self-identification among racialized groups. There are enough examples and anecdotes to know that racism in healthcare is real. As mentioned on the Mentimeter, transparency and accountability are critical. The purpose for collecting race-based data must be clear, and how the data will be used must also be stated. Staff who will be collecting the data must be provided with adequate training and resources to support high-quality data collection. Race and ethnicity are distinct concepts. Race is a social construct used to categorize people based on perceived physical differences, things like skin color or facial features. There is no scientifically accepted evidence of a biological basis for the identification and classification of discrete racial groups. Race is not about genetics, but disaggregating health system indicators by race can help us to identify, monitor, and address inequities that stem from racism, bias, and discrimination. Ethnicity is a multidimensional concept referring to cultural group membership, and it may be connected to other factors such as language, religion, or nationality. Ethnicity data can be useful for tailoring culturally appropriate health services, particularly at the local level. Should you wish to collect and understand the role of ethnicity, it is important to understand which components of ethnicity is of interest. Ethnicity may be interpreted as a person's ethnic or cultural background, their language, immigration status, religion, or country of birth. In some cases, it may be more appropriate to ask about these various dimensions of ethnicity rather than ethnicity more broadly. For example, collecting language data in addition to race-based and Indigenous identity data can help determine the language translation resources needed for a local population and potentially identify healthcare barriers faced by racialized groups. CIHI released guidance and standards on racialized group and Indigenous identity for voluntary adoption by health systems. The standards include 2 data collection items, a distinctions-based measure for Indigenous identity and a race-based data element. These standards will support the measurement of inequalities in care and the identification of health inequities that result from racism and discrimination. Community engagement, data governance, and processes for the safe collection of data are essential for implementation. This is the final set of standards that can be voluntarily adopted. There's a distinctions-based question on Indigenous identity to allow for flexibility in the way Indigenous people choose to self-identify. This approach separates out First Nations, Inuit, and Métis groups. The race-based standard is adapted from the Ontario Anti-Racism Directorate. A preamble is included, and this is a self-reported, self-identified approach to measuring race, and respondents can select all categories that apply. These standards are minimum standards, and we encourage jurisdictions to use additional granular categories to suit the needs of their populations. For example, the Fair Care Project in Nova Scotia is collecting data province-wide as part of the health card renewal process. Based on extensive community engagement, they have included African Nova Scotian as a racialized group response option. They are also collecting data about language spoken with a separate question. At CIHI, We have seen an increase in racialized group data collection across a few data systems, largely in survey-based data collection, and we are learning along the way. For example, as part of the shared health priorities work, pilot testing revealed that respondents did not have any issues responding to these questions. This survey is administered electronically, which means that the respondent themselves are reading the questions and inputting their response. We also see these standards as part of the Commonwealth Fund survey. They are preparing to collect the data by phone from older adult Canadians in the spring. And in this case, there were concerns about the preamble being too long. So they only asked the last part of the race-based question, and the longer preamble is available if respondents ask for clarification. Finally, we also see the race-based question being collected as part of patient experience surveys, which collect data on hospitalization experience after discharge. In this case, the data is collected in print, electronically, or by phone. When collecting the data by phone, they moved the Indigenous identity and race-based questions to the end of the sociodemographic section of the survey. These examples highlight the need for flexibility in the standard while maintaining as much consistency and alignment with the original form as possible. We've been tracking the impact of the guidance document since it was released in March of 2022. The metrics on this slide demonstrate its successful impact. The reach has been far and wide. The Canadian Medical Association Journal published new guidance on the reporting of race and ethnicity in research articles, which employs the CIHI definitions. As researchers, it is worth reading that article. The BC PHSA endorsement of the CIHI guidance document is captured in the category of guidelines for research or professional practice.
So we've had a chance to reflect on your hopes and concerns, and now I'd like to turn your thinking towards the organization you work within. And so to really have a chance to think about what systems or resources are already in place to support this work. What already exists that you can leverage for positive change? Yeah, and I was hoping we would see the answer, I don't know, because there's a very good chance that most of us don't know. And something that we're going to talk about later is that organizational readiness and that importance of learning about our organizations to help us be able to answer this question, but also to help us build the systems and create the resources to support this work. I see mention of OCAP principles. Yes, First Nations principles of data sovereignty are so clearly articulated and so helpful for us to understand how we can respect First Nations data sovereignty and how First Nations can assert data sovereignty. And yes, again, with respect to First Nations, having the First Nations Health Authority in your province is an incredible resource. And I see you have a local Indigenous health office as well. You have an EBI team, survey research abilities. So there are systems in place, there are resources available, but perhaps this is an area for personal growth to really uncover and an area for us to learn more together as well, to find out what needs to be created and what can be leveraged that already exists. And this may be the time too to jot down any answers that you're not familiar with and that you can explore more about on your own time. And so the next question we have for you is, what needs to change in your system for this work to be successful? What is standing in the way of progress? What could be different? Yeah, resources, training, cultural safety. And again, we're not always sure. This is an early phase of this journey for PHSA, and while much great work has been done to get us to this point, to get PHSA to this point, there's still a long road ahead. And sometimes identifying what needs to change can be a good starting point.
So some of the resources to support you with this work are identified in the guidance document. It's a good starting point for starting to understand where you can look to some of those resources to support this endeavor. Community engagement is one of the key themes that we heard, and one of the areas where resources are provided or highlighted as part of the guidance document. Community engagement is best practice and foundational to the respectful collection and appropriate use of race-based and Indigenous identity data in healthcare. Community members and organizations are knowledgeable about their health priorities and broader social, political, economic, and historical context of their communities. The engagement process needs to be organized and thought out in advance. There are a number of ways to promote community involvement, including the creation of community governance tables, as advocated by the EGAP framework. You could also consider using a framework such as the IAP2 spectrum, as depicted on this slide, in planning for engagement and the roles of various groups. Strong data and information governance ensures that data is timely, trusted, and accurate. Data and information governance mechanisms, including policies, processes, systems, and practices, should be reviewed and revised as needed, with special focus and consideration given to the impact on Indigenous peoples and racialized groups. Indigenous data sovereignty principles, for example, First Nations OCAP principles, assert that First Nations, Inuit, and Métis peoples have collective sovereign rights and the fundamental authority to own and govern their data, regardless of where their data is housed. Data governance mechanisms need to be in place before you start asking these questions in healthcare settings. You need to be able to answer the question, what will we do with this information? Who will have access? Who won't have access? Who makes decisions about the use of this data and how? And who will be interpreting and analyzing this data? Can we trust them not to perpetuate stigma and harms to the community? It is also important to think about data flows both within your organization and potentially to the outside to identify where safeguards may be needed. We also need to consider, anticipate, and mitigate any potential harms to collecting this information. Providing staff training and clear information to patients about the data collection process can facilitate culturally safe data collection. These practices reduce the risk of harm and improve the quality of the data that is collected. Some examples of staff training and support for patients include a staff script for the data collection. Also, providing staff with answers to frequently asked questions helps them better able to answer questions that might arise as part of the data collection process. Additional resources such as training or courses on topics such as implicit bias are also useful for staff. In all of the staff training and the supports for patients, it is important that the clear purpose for the data collection is clearly articulated. Transparency with why the data is collected, including an explanation of the risks and benefits, should be provided so that patients and clients have the choice to share this information. It's also important to implement processes and create infrastructure to ensure data privacy, confidentiality, and security. This shows a few examples of progress and action from across the country, but there are many other examples of initiatives to collect and use race-based data to improve the delivery of healthcare. So for example, the BC Office of the Human Rights Commissioner report released in September of 2020 was released amid numerous calls for the collection of race-based data as part of the COVID-19 response. In this report, it states that by making systemic inequalities in our society visible, data can lead to positive change. The same data, used or collected poorly, can reinforce stigmatization of communities, leading to individual and community harm. In Nova Scotia, they've enacted the Fair Care Project, which is the systematic collection of race-based data as part of the health card renewal process. As part of this, they've set up community governance tables to handle those requests from the research community. Similarly, in Manitoba, they're collecting race, ethnicity, and Indigenous identity data as part of the registration process in acute care settings across the province. In all of these examples, the purpose of collecting race-based data is to be able to stratify healthcare indicators by racialized group, to identify differences that stem from racism. We want to measure variations in healthcare quality across different population groups as a starting point for quality improvement initiatives. And as a quick note, building on our analytic experience and with the help of an external working group, CIHI's population health team developed a web-based toolkit for measuring health inequalities. The toolkit is organized into 3 phases for measuring inequalities: planning your analysis, analyzing the data, and reporting the findings. The standards presented today are just one piece you can find in that toolkit. It also includes many other resources and guides for health equity analysis.
So we know that community engagement, data governance mechanisms, and processes for the safe collection of data are essential to this work. We also know that there's a lot of work that needs to be done in an organization before you can approach community engagement with the humility, the openness, and the respect that each distinct community deserves. And so we thought we'd share some lessons we've learned along the way about the importance of organizational readiness and getting your own house in order and doing the hard work to get ready for the processes that follow. So I'll share some ideas. Maybe they'll spark some ideas of things you might want to consider to ensure that you as an individual, perhaps your research entity, or the broader organization of PHSA, to help you get ready for the engagement and data collection that needs to happen. So the first lesson we've learned is how important it is to drop your agenda and be open to doing things differently in response to community priorities. We've learned about how important it is to reflect on your and your organization's positionality, your privilege, your power, and your priorities, and to think about how do those things differ for you from those you're trying to engage. And where can you and your organization bend and adapt for better alignment with community priorities? As an organization, CIHI still has a lot to learn and a long way to go, but we've put a lot of time, energy, and resources into building a culture of humility and what we're calling our foundational capacity to engage with humility. So in 2020, we signed a declaration of commitment to advance cultural safety and humility in health systems, both within CIHI and through our circles of influence. We have things like mandatory staff training on our shared colonial history, on colonialism as a social determinant of health, on Indigenous worldviews and data sovereignty. We've also implemented a formal equity, diversity, and inclusion strategy and a commitment to ongoing learning. And that includes mandatory training for all staff on the foundations of diversity, equity, and inclusion in the workplace, as well as an ongoing speaker series and staff learning opportunities. We work hard to recognize significant days and events with meaningful content and change and speakers like Black History Month, National Day for Truth and Reconciliation, Diversity Month, and more. And we've learned that the organizational readiness process doesn't have an endpoint. It's a process of continual learning and unlearning, and it necessarily involves every single person at your organization, no matter their role or title. And we think too about the importance of learning together and learning from each other. So for us as a Pan-Canadian health organization, we work closely with our peers with other Pan-Canadian health organizations. And this might give you a chance to reflect on who are your peers both within your province and outside of your province, and how can you learn from each other? We're all at different stages along this journey, and having conversations and open dialogue about what's going well, what's been challenging, is very important to getting us on the right track. So once you've done some of that hard organizational readiness work that has no end, that will continue forever, you can think about how to engage respectfully. And we've learned a lot about how to engage respectfully, and we've also learned some hard lessons about how not to engage. And some key takeaways that I'd like to leave you with today are: partnerships begin at the very beginning, before data is collected, before a research question is developed. And trust is key, and to build trust, you need to respect community protocols, timelines, cultural differences, and community priorities. And as an example, a pan-Indigenous approach simply will not work. And trust only comes when you can demonstrate local relevance. And to think about, can you answer the question, how will this make things better for me and my community? How do I know this won't make things worse for my family and friends? Through community engagement, you can also start the conversation about data governance mechanisms, and these conversations need to happen early. And data governance encompasses so much more than data access. These mechanisms need to be in place before you start asking the questions, and you need to be able to answer those questions Dana shared earlier. What will we do with this information? Who will or will not have access? Who makes decisions about the use of this data and how? Who will be interpreting and analyzing the data? And can we trust them not to perpetuate stigma and harms to community? Following engagement and the work to co-develop the answers to those data governance questions, you can then begin to think about how to ensure that the benefits of collecting this information outweigh the risks of asking someone to self-identify in a healthcare setting. You can think about how you might answer the question, what's in it for me if I self-identify? Perhaps you have patient navigators available or translation services. And you can work with partners and care providers throughout your organizations to co-develop staff training and staff scripts, but also public education initiatives so that folks aren't surprised when these questions are asked. Frequently asked questions documents to support staff in doing this well, and to make sure that staff themselves feel safe in asking the question and have clear, consistent responses when a patient or client asks, why are you asking me this question? And while this might seem like a lot, and it is, it all begins with humility and an openness to listening, to sitting in your discomfort, and to committing to working in partnership. And this is hard work, and there are real risks to doing this poorly, but there are also so many real opportunities if we do this well and in partnership and through co-development of the critical processes we need. And if we can focus on the common goal, that we all want the same thing. We want equity in healthcare. We want cultural safety in health systems, both for those who receive care as well as those who provide it. And we want better health for all. When we think about these things, this process becomes simpler, and we need to really sit in the discomfort and start to ask the hard questions about, what do I need to learn? How can I do better as an individual? And so I want the next question for you to think about, what do you need or want to learn more about? And we've set this up so that you can try ranking these things. If you could pick the first thing you need to learn more about, what would it be? What's most important to you? Recognizing that you may need to learn more about all of these things. And so as you reflect on this, I know that your colleagues, Holly and others within PHSA, are also keen to hear what you share here and keen to support you in learning. the next steps of this journey. And if CIHI can play a part in that, we're happy to continue to help as well. Yeah, and so culturally safe data collection and community engagement appear to be at the top. With data governance a close third. And as researchers, yes, I would expect you'd be keen to learn more about analysis and interpretation. And as I look at this, I may have wanted to rephrase it and say, you know, co-analysis and co-interpretation, or are there ways to think about how we need to do analytical work differently with the collection of race-based and Indigenous identity data? Learning about community priorities, absolutely essential and a large part of that community engagement. But it's really heartwarming to see that culturally safe data collection is up there at the top, because it's critical to know that we want to make sure that the people we care for in our health systems feel safe, and that we are working to enhance their cultural safety in health systems. And so for our final Menti question today, I want you to take some time to reflect on what we've discussed today, what you've discussed with your peers over the previous weeks, months, or years. When you think about race-based and Indigenous identity data collection and data use, what can you as an individual commit to moving forward? So maybe setting up a data governance protocol or learning about existing data governance protocol. I love this, and openness to continuing to learn more, checking out some of the resources we mentioned, reviewing the CIHI documents. I love being curious. That will help you achieve such great things if you enter engagement with a curious, open mind. Yeah, upholding the rights of Indigenous peoples according to the Declaration on the Rights of Indigenous Peoples and the Act in BC. You're in such a unique position in your province, given the commitment to the United Nations Declaration. Being open and flexible with processes, and continuing to learn more. So there's a lot that we can all do as individuals, and there's a lot that we can learn from each other, and CIHI will be happy to be here as a resource where it makes sense, and look forward to seeing you through this journey as well.
Wonderful. Thank you guys so much. That was very thoughtful and interesting. And we have so many questions in the Q&A. I just want to mention, of course, that there's obviously too many questions that we can answer today. We are going to get back to you in a few days with the video, with the slides. We're going to have a link to the PHSA research roadmap statement that also links to the CIHI guidance document, a survey that we want you to complete. But like I said, all these questions will be answered, just probably not in the next 10 minutes, but it'll go back to everybody. So it's not like we're trying to leave anybody out. I'm going to do it in order that they came in. One of the comments that I see, this is decolonization. I think that's what's intended. I'm very hopeful for that. Next question for our CIHI colleagues. How many provinces are using the optional race collection fields in DAD? And have you looked at the completeness?
I can answer that question.
Sure.
And the answer is not very many. Mainly because most provinces and territories are pretty early on their race-based data collection journey. And as a result, the data is being used more locally than to worry about submitting the data to CIHI. That being said, we did make it available should any province, territory, or jurisdiction be interested in using them. We did see some data coming through in Saskatchewan, in Saskatoon specifically. And so I actually connected with the folks in Saskatoon to learn a little bit more. And that's one area where, similar to Fraser Health and elsewhere, they prioritize collecting Indigenous identity data at the point of care. And they actually use that data to justify hiring more Indigenous navigators to support Indigenous patients on their journey in healthcare. And I mean, that was something I knew from asking the questions, because you don't get that from the data. We had to probe a little deeper to get that. But I would expect that perhaps we would see an increase in the use of those fields in DAD as this type of data collection advances across the country.
Thank you for that. That's interesting. And the next question is about linking to the CIHI document. Yes, those materials will go out, absolutely. Here's another question for you all. Does the Indigenous identity standard work for global Indigenous peoples? For example, someone living in BC who is Maori. Also, are the recommendation standards related to Two-Spirit identity?
I can take this one. So right now, the Indigenous Identity Standard is designed for First Nations, Inuit, and Métis data collection. But there is the option for local customization. And perhaps if you are seeing a larger population of Indigenous peoples from other countries, there may be an option to collect that data, and that may be something of interest. But of course, it would be really important to make a distinction between those people who live in our country who have been subject to colonial harms and the way we look at and interpret this data. And I'll pass it over to Dana to comment a bit more on that through the development of the standard, but I will say CIHI is working right now on gender, sex, and sexual orientation standards, which will include Two-Spirit identity. And so we can stay tuned for that, and we can share more about that, or perhaps about upcoming webinars on that topic. Dana, did you want to add anything about the international Indigenous population?
No, I think you covered it. It would be adding an option for another Indigenous identity as part of that broader capturing of that information.
So next question for you. Is there a way of knowing that we've achieved saturation around the perspectives of historically marginalized and equity-deserving communities? And if any of these questions require a more additional thought for us to go back and come back later, that's perfectly acceptable. You could say, let me think on it.
I feel like this question maybe came from somebody with more of a qualitative background. And so when we think about achieving saturation, we can't answer that. It's your respondents who will answer that. So if the findings that you've interpreted resonate when you go back to do the community engagement, to talk about what you're seeing in the data, if you're not getting anything new from the information, I think that's probably the best way for you to determine how saturation is achieved.
Yeah, and the only thing I might add to that is that we know there is a burden to sharing your story, and to sharing your story many times. I'm thinking specifically about the work our team is doing right now around measuring cultural safety or data to address anti-Indigenous racism. And so it's important too to do your research and homework and leverage those existing stories that have been shared, like in BC, the In Plain Sight report and other things, but to bring those back to the community you're working with each time, and to say, does this resonate? Does this reflect? Should we continue to use this? To make sure that we're balancing the possibility that stories change, or maybe we're in a new climate and people feel safer coming forward with even more stories, but also really appreciating that asking people to continue to share with us is very difficult as well.
Thank you. And should we call it ethnicity data or race data if race is a social construct with no biological bearing? How do we use the term correctly in our communications and strategies, etc.?
This is something that came up time and time again as we continue to learn in this space. That's why we called it race-based data. We included the word based to really get at that underlying social construction of the concept. And so the preferred terminology for the CIHI guidance was race-based data. That being said, if ethnicity is the area that you're interested in, thinking about those different dimensions of ethnicity and how you're going to collect and report on that information, it really needs to be as locally relevant as possible.
Yeah. And we all had a conversation about that because at the PHC research roadmap, our leadership was very specific that it would to be race-based ethnicity and Indigenous identity data. And so it's an interesting, thoughtful conversation around those things. The next question is around the Jedi Council, and I'm not sure which council that was talking about. Who was on the Jedi Council, and is there a way to join? That's one of the things you guys were talking about during your presentation. And if we're not sure what that's in reference to, we can come back and answer it later.
I wish it was Star Wars.
Yes. A comment here about the CC button being deactivated and making sure that the session is accessible. We'll look into that. It might be too late, but for our next sessions. Okay, sorry about that.
Perhaps for the recording as well. Yeah.
Okay. Next question for you all, and probably our last one because we're going to stop right at 1 o'clock. Will Health Canada align to assure race and ethnicity data collected on clinical trials in Canada are in line with CIHI standards? And does staff training include the purpose of collection in the context of clinical trials? Do we know about Health Canada? If we don't, that's okay. We can always follow up.
I don't know the answer off the top of my head, but it's certainly one of the questions that we could do a little bit more background research and provide when we provide the follow-up from the webinar.
Yeah. I know that there's certainly been a ton of chat in the clinical trials community, like internationally, about these issues, and the FDA and others have issued statements. And I know Health Canada has issued statements like a long time ago that have never really been acted upon. But we'll get more fulsome information and get it back to this community. And will we get a copy of this is the next question? Yes, we will. There's a next question is really for the PHSA, and it's about the consultation with communities within here. In 4 minutes, I'm sorry, I don't have time to get into that one, but we will ask our Indigenous health colleagues and others to give you a nice fulsome understanding of consultation efforts that are currently underway and get it back to everybody on this call. And again, there's another question about PHSA working on organization-wide data governance policies for information on race, ethnicity, gender, and et cetera. And both of those questions, there's a lot of fulsome information around there. So I don't want to give curt answers. And I also don't want to put John on the spot to answer something that should be in many paragraphs in one sentence. So we will get back to all these as and there's lots of there's now 31 questions. They're all excellent and thoughtful. Thank you so much for putting your questions in there. I want to take the last 3 minutes here to thank our CIHI new colleagues that I hope we will be doing more work with in the future. There's more than just Dana and Liz involved here. There's a whole big team that did lots of work around this. Thank you so much for our speakers for being willing to speak, John and Gina and Ellen, and of course the leadership, the research leadership of PHSA for taking on this. Gina, they're taking on this incredible research roadmap, which is truly exciting. And if you don't know about it and you're at PHSA, Google it and look it up. We will be sending it to you. But it's a real statement that shows how, as a community, we're coming together to do very, very, very difficult things. Remember, there was nearly 500 people that signed up for this event. So with that, with 3 minutes to spare, Liz and Dana, if you have anything left that you would want to say, and we'll wrap it up.
I would just say that if you have more questions for us, you can reach us at indigenoushealth@cihi.ca or populationhealth@cihi.ca, and we're happy to continue the conversation, happy to have more focused conversations about specific things you might be interested in. And we've just really enjoyed getting to connect with you, Holly, and your team, and appreciate the opportunity to speak today.
Yeah, it was great to be here today.
Excellent.
Thanks for the opportunity.
Oh, it's our complete pleasure. And Ellen says, thank you, everyone, to everyone, all the panelists, and of course, everyone who took the time to come here today. You have 2 minutes to spare to get to your next meeting. So we'll close it up at that. And thank you again.
Thank you.
Bye, everyone.